So I will be talking about synovial fluid analysis. These are the learning objectives that we are to achieve for this lecture. Now, before we move on, let's define some terms that we will be using all throughout the discussion. So synovial fluid, also termed in simpler terms as joint fluid, is actually a viscous liquid found in the cavities of the movable joints or synovial joints. Basically, the substance responsible for it being viscous is actually it having hyaluronic acid. And take note that this fluid is actually found in the spaces in between synovial joints, which serves to lubricate articulating joints. Then we have synoviocytes. These are actually cells lining the synovial membrane. And then we have hyaluronic acid. It's a mucopolysaccharide secreted by the synoviocytes. Okay? This is the substance responsible for the viscosity of synovial fluid. Arthritis refers to the pain and stiffness in the joints due to damage to the articular membranes. Then arthrocentesis is a procedure of collecting synovial fluid from joint. Now, this is a picture showing us an articulating joint. Okay? Take note that the two bones okay, actually do not come in contact with each other. In fact, they are lined by an articular cartilage, and inside that articular cartilage is actually an articular space. Okay? And that articulating space is where you can find your synovial fluid or joint fluid. Your synovial fluid serves to provide nutrients for the cartilage, and it also acts as a lubricant. Okay? That's why it's basically found in between joint spaces. And the hyaluronic acid content is responsible for its viscosity and its lubricating effect. So it being acting as a lubricant serves to reduce the friction in between articulating joints and also lessens the shock of joint compression. Your synovial fluid is actually an ultrafiltrate of plasma across the synovial membrane. That's why basically its content is more or less the same, with that of the plasma. Now, the ultrafiltration process that happens is actually non-selective, except that the high molecular weight proteins do not go in, okay? Do not actually mix in with synovial fluid because of its molecular weight. And since this is an ultrafiltrate of a plasma, I've mentioned already that the values are actually similar to the plasma. Okay? However, synovial fluid does not typically clot, but usually in inflammatory states, where there is increased fibrinogen, may cause clotting of the synovial fluid. Now, the synovial cells, okay, or the synoviocytes lining the synovium actually secretes the mucopolysaccharide. And what is that mucopolysaccharide? The hyaluronic acid, okay, which is responsible for the viscosity and the lubricating effect of the synovial fluid. And synovial fluid actually just present in a small amount, particularly in a large knee, about less than 3.5 ml. Okay? However, in inflammatory states, you get to have an increased level of your synovial fluid, maybe around 25 ml. Now, an increase, okay, in the synovial fluid is actually enough to aspirate is due to some diseases, in particular maybe in inflammatory states, as I mentioned a while ago. Now, these are the indications for arthrocentesis or collecting synovial fluid. Okay? To diagnose the cause of synovial fluid formation by this phrase, no, we actually mean increased synovial fluid formation. Okay? To differentiate inflammatory to non-inflammatory causes of synovial fluid accumulation, and to see if the arthritis is actually caused by crystals like gout or pseudo-gout. Usually for gout, these are caused by monosodium urate crystals, and for pseudo-gout, it is caused by CPPD crystals. Okay? Or to evaluate if there are any malignancies causing this increased formation of synovial fluid, and for administration also for medicines like corticosteroids and to monitor chronic arthritic diseases. These are the other indications for arthrocentesis. Okay? Now, these are the contraindications to intra-articular injection. Now, I've mentioned that synovial fluid can actually be aspirated, can be collected from joint spaces or from articulating or movable joints. Okay, so these are actually the sites wherein we could perform arthrocentesis. Okay? So in collecting the specimen, we should take note that we do not use powdered anticoagulants. Why? Because your powdered anticoagulants may actually cause artifact formation that may interfere with crystal analysis. Okay, so remember, we when we do synovial fluid analysis, there's actually the parameter we're in. We check for any crystals seen in the fluid. And if we use powdered anticoagulants, chances are you get to have artifacts that might be mistaken as crystals. Okay? That's why we need to do away with using powdered anticoagulants. And also to note, however, synovial fluid does not normally clot, but in disease states where there is increased fibrinogen, the fluid may be collected in a syringe. Okay, why? Why in a syringe that has heparin? Why can we use now an anticoagulant? I mentioned that your synovial fluid does not normally clot. But how come in disease states when there is increased fibrinogen, we opt to use anticoagulant, which is heparin? It's because your fibrinogen is actually a clotting factor, okay, which is responsible for increased clot formation in synovial fluid. And if your synovial fluid is actually clotted, we could not proceed with the analysis. The non-anticoagulant test tube should be centrifuged to prevent these cellular elements from interfering with the chemical and serologic analysis. Okay? Such that after centrifugation now, your cellular elements will be separated from the liquid component. of your synovial fluid. And all testing should be done as soon as possible to prevent cellular and possible changes in the crystal. Okay? Because maybe your cellular elements and your crystals might disintegrate if we actually prolong. Okay? We do not do the testing or analysis right away. So the specimen collected is distributed into the following tubes based on the required test. Okay. So we collect tubes in a heparinized tube for microbiology tests. No? Usually for microbiologic testing such as gram staining and culture. We collect a specimen anticoagulated with EDTA or heparin. Usually we use this for cell counting. A non-anticoagulated tube for other tests, maybe for some serologic tests or other chemistry tests. And we collect a gray top tube, no, containing sodium fluoride or glucose analysis. These are the normal values for synovial fluid analysis parameters. So I've mentioned already that your synovial fluid is actually found in smaller volume, but however, in disease state, it may reach up to 25 ml. So normally, it's less than 3.5 ml in volume. And the color is actually colorless, no? To pale yellow. And it's usually clear, and it is actually viscous, no? Due to the presence of what, again, substance? Hyaluronic acid, such that it is able now to form a string 46 cm long. The cellular contents are as follows. So it may contain less than 200 cells per UL, no, of leukocytes. And of these leukocytes is comprised of less than 25% of neutrophils. Okay, usually, you do not see crystals. However, in gout or pseudo-gout, you might see some crystals. Okay? And since this is an ultrafiltrate of the plasma, usually it also contains glucose. No? However, the glucose content of your synovial fluid is less than 10 milligrams per dl than your blood glucose levels. And the total protein also is lesser. Okay? Why? It's because remember, your protein is actually a high molecular, it may be, no, a high molecular weight substance. And usually your high molecular weight substance do not actually pass through this ultrafiltration process, although it's non-selective, but due to its high molecular weight, it does not go into the synovial fluid. Shown here is a classification and pathologic significance of the different joint disorders. Now, it may be classified as non-inflammatory, inflammatory, septic, or hemorrhagic. Okay? So under non-inflammatory are your degenerative joint disorders such as in osteoarthritis. Under inflammatory, we have rheumatoid arthritis, lupus erythematosus, or SLE, scleroderma, polymyositis, and among others. Under septic category, we have a joint disorder caused by some microbial infections. Okay? Under hemorrhagic, okay, hemorrhagic would actually mean presence of increased red blood cells in your synovial fluid. No, it may be caused by traumatic injury, okay, or tumors, or hemophilia. Okay, hemophilia is a disorder wherein you have decreased clotting factors such as factor 8 and factor 9. Okay? And other coagulation disorders, anticoagulant overdose. Now, these are the laboratory synovial fluid parameters you expect for each category. No? So under non-inflammatory would actually mean that there's actually no immune response, no logic response involved in the disease process, no, caused by by these conditions such as degenerative joint disorders, arthritis, okay, you usually get to see a clear yellow fluid with good viscosity. However, your WBCs may reach up to 1,000 microliters per cells per microliter. Your neutrophils is usually less than 30%. However, you get to have a normal glucose level. In inflammatory joint disorders, okay, for disorders with immunologic origin, you usually get to see a cloudy yellow fluid. Now, this cloudy yellow fluid may indicate that there is actually an increased cellular element in your synovial fluid. Thus, the WBC is reaching up to 75,000 cells per UL, and usually these WBCs comprise majority of your neutrophils, that is more than 50%. Okay? Now, since you have higher cellular elements, these cellular elements may actually consume more glucose, okay, for requirement, cellular requirement, metabolic requirement. That's why in inflammatory states, you get to have decreased glucose levels in the synovial fluid, okay, and also possible autoantibodies present. Now, in crystal-induced origin, you get to have cloudy or milky fluid, okay, although the WBCs may reach up to 100,000, comprised mostly of neutrophils. Now, another cause of the cloudy or milky fluid is actually another component, which are the presence of crystals. Okay, presence of crystals. Now, still the glucose is increased due to the presence of larger number of cellular elements. Now, in septic joint disorders, okay, you usually expect to see a lot, okay, a lot of cellular elements, particularly WBCs reaching up to 100,000 cells per UL, and a majority of these are neutrophils. Now, these presence of your WBCs may actually cause increased turbidity of the synovial fluid. And also to note that in microbiologic testing, you may get to isolate the organism, okay? Thus the positive culture and gram staining result. In hemorrhagic joint disorders, you actually get to see a fluid with reddish, reddish tinge or red streaks. This is actually due to increased levels of red blood cells leaking out into the synovial fluid. Okay. Now, there's actually no defect in the number of cellular components. However, just the presence of the red tinge in the fluid, and you usually get to have normal glucose levels. Now, we also have this what we call classification of synovial fluids. Okay. Now, this table shows us the different classifications. So under group 1, 2, 3, 4, and 5, and the usual appearance of the synovial fluid and its respective viscosity and mucin clot. Okay? Mucin clot is actually a test to determine if you have enough hyaluronic acid. This is used to detect the presence of hyaluronic acid in the synovial fluid, wherein you add acetic acid. So usually, normally, you have a good mucin clot test. Okay? However, in disease states, you get to have decreased or poor mucin clot. And shown here also are the different cell counts, blood glucose levels I have mentioned. So first and foremost, we do macroscopic and microscopic analysis, also chemical analysis of your synovial fluid. So the first parameter is identifying its color and clarity. So I've mentioned that normally it's colorless to pale yellow. Okay? It becomes deeper yellow in the presence of non-inflammatory and inflammatory conditions, and may be greenish, no, with bacterial infection. So presence of blood may impart what color again? Okay, reddish color. Maybe due to hemorrhagic arthritis or from a traumatic aspiration. Now, usually turbidity is associated with the presence of, I mentioned already, increased cellular elements, no, particularly your WBCs. Okay? And the fluid also may appear turbid or milky in the presence of crystals. Okay? Most common crystals are your monosodium urate crystals in what condition? Gout, or CPPD crystals in pseudo-gout. Now, viscosity, again, I've mentioned, is actually caused by what substance? Hyaluronic acid, such that normally your synovial fluid is viscous, such that it forms a string. Now, when you held the fluid to form a string from the tip of a syringe, it should form a string that measures 4 to 6 cm. Now, in arthritis, what happens in arthritis is that there is articular damage. Okay? And this articular damage actually cause decreased production of your synovial fluid. Thus, your articulating joint surface would actually be inflamed or damaged, okay, in arthritis. That's why usually in these states, your hyaluronic acid being responsible for proper lubrication is actually decreased. No, thus, the pain and stiffness seen in arthritis. Now, I've mentioned already that a test to measure the amount of hyaluronic acid or hyaluronic polymerization is this what we call mucin clot test or ropes test. Okay, so you add acetic acid 2.2 to 5%, 2 to 5%, and normally when acetic acid is added to hyaluronic acid, it causes polymerization. Okay, thus forming a solid clot surrounded by a clear fluid. Now, as the ability of the hyaluronate to polymerize decreases, the clot becomes less firm and the surrounding fluid increases in turbidity. This is usually found in disease states, and this is, however, not routinely performed. But this is a good test to determine if the fluid is actually synovial fluid. Okay? So this is how we report the test. We report it as good, fair, low, and poor, depending on the quality of the clot. So another parameter is cell counting. Okay? So usually we do total leukocyte determination or WBC determination the same manner as we do this in the other body fluids such as your CSF. Okay? Now, I'd like to point out that usually we do this immediately after collection of the sample. No, we do not cause any delay because the cellular element actually may disintegrate when you actually prolong the or delay the counting process. However, if there is delay, if you anticipate any, so the specimen may be refrigerated. Very viscous fluid may need to be pre-treated by adding a pinch of hyaluronidase, okay, to 2.5 ml of fluid or a drop of 0.05% of hyaluronidase in phosphate buffer. Now, this is usually done in a Neubauer counting chamber, and usually clear fluids can be counted undiluted, but dilutions are necessary when fluids are turbid or bloody. Remember, I mentioned that major cause of the turbidity of the synovial fluid are actually presence of increased amounts of cellular elements. That's why if more of these cellular elements are present, the more we need to dilute the specimen. That is to facilitate counting of the cellular elements. Okay? Normal saline may be used as a diluent. If necessary to lyse red blood cells, hypotonic saline or saline that contains saponin is suitable. You may opt to add methylene blue to the diluent, that is to stain WBC nuclei to facilitate counting. And usually WBC counts less than 200 cells per UL are considered normal. It may reach up to 100,000 or higher in septic or infections, septic states or infection. Now, remember I've mentioned that neutrophils account for less than 25%, okay, of the total WBC count, and lymphocyte is less than 15%. Usually this may rise up probably up to more than 75% of your neutrophils, usually in inflammatory states or septic, okay, septic joint disorders. Other abnormalities include the presence of your eosinophils, LE cells, or lupus erythematosus cells, Reiter cells, which are actually vacuolated macrophages with ingested neutrophils, and RA cells or rhagocytes. These are neutrophils with small dark cytoplasmic granules that consist of precipitated rheumatoid factor. So these are the different cellular elements or other components that we may see when doing microscopic examination, okay, of your synovial fluid with its specific description and appearance, and the disease states or conditions associated with such. Okay, so please go have a look into this. Now, this is a sample right stained synovial fluid, okay, wherein the cell labeled A actually a neutrophil. Okay, the cell labeled B is a lymphocyte. The cell labeled C is actually a monocyte, no? And we have here a histiocyte or a macrophage cell labeled D. Then this is actually a right stain smear from a patient, no? Synovial fluid of a patient with septic arthritis. Okay, notice the predominance of your segmenters or neutrophils. So this is an LE cell. Okay, notice the neutrophil, okay, with ingested cellular nuclei component. Okay, an LE cell. This is um, a Reiter cell. Okay, so this is actually a macrophage with ingested neutrophils on it. Okay, a Reiter cell. This is a TART cell. Okay, this is a macrophage with a nuclear component ingested with it. And this is a lipid-laden macrophage. Okay, right stained lipid-laden macrophage. Now, another parameter that we do and that we assess in microscopic analysis of synovial fluid is to identify the different crystals. Okay, I've mentioned that the most common crystals seen are monosodium urate or uric acid crystals and CPPD or calcium pyrophosphate crystals seen in pseudogout. Okay. Now, these are the conditions more or less associated with gout, no? Or uric acid formation in the synovial fluid. However, pseudogout is most often associated with degenerative arthritis, producing cartilage calcification and endocrine disorders that produce elevated serum calcium levels. Additional crystals that may be seen include hydroxyapatite crystals, okay, associated with calcified cartilage degeneration, or you may get to see also cholesterol crystals associated with chronic inflammation, or even corticosteroids following injection. Also, calcium oxalate crystals in renal dialysis patients. That's why when doing synovial fluid analysis, we should have an overview, no, background of or a knowledge on the history of the patient, medical history of the patient. Now, artifacts may include talc and starch from gloves or precipitated, particularly powdered anticoagulants, no? Also dust, scratches on the slides, and cover slips. So how do we prepare the slide for crystal examination or identification? So this is performed immediately after the fluid is collected to ensure that the crystals do not disintegrate. Okay, because crystals are actually affected by any changes in temperature and pH. Both monosodium urate and CPPD crystals are reported as being located extracellularly and intracellularly within neutrophils, and therefore fluid must be examined prior to WBC disintegration. Okay, that's why we do this immediately after specimen collection. Usually, the fluid is examined in an unstained wet preparation such that a drop of the fluid is placed in a glass slide and cover slipped. And the slide can be initially examined under low and high power using a light microscope. So once the presence of crystals has been determined using direct polarization, a positive identification is made using compensated polarized light. Okay? Now, both MSU and CPPD crystals have the ability to polarize light. However, MSU is more highly birefringent and appears brighter against the dark background. So usually, your MSU crystals would appear yellow and usually is negative, no? Negative birefringence. Whereas your CPPD would appear blue in color with positive birefringence. So these are common crystals that we get to see, no, during crystal identification in synovial fluid analysis. So your monosodium urate crystals would appear as needles, no, with negative birefringence, usually seen in gout. Your CPPD crystals would appear rhombic or rods, no, rhombic square or rods with positive birefringence seen in pseudo gout. Your cholesterol crystals would appear notch or rhombic plates, okay, with negative birefringence, usually found extracellular. Your corticosteroids would appear flat or variable shaped plates, no? Maybe positive or negative birefringence, usually seen in when you inject corticosteroid. Your calcium oxalates would appear as envelopes, no? It's the same with appearance in urine, usually but with negative birefringence, usually seen in patients with undergoing renal dialysis. And your calcium phosphate or your apatite crystals would appear as small particles, no? Usually a triple phosphate or coffin lid appearance, no, with no birefringence, usually seen in osteoarthritis. So these are actually the typical yellowish, okay, appearance of your needles, no? Notice the needles appearance of your monosodium urate crystals. This is a neutrophil, okay, seen with CPPD crystal intracellularly. This is another neutrophil, no, with CPPD crystal inside. And more neutrophils with CPPD crystal. Okay, so notice the appearance of your needle crystals, no? Particularly characteristic of your monosodium urate crystals. And on birefringence, okay, your uric crystals would appear as yellow. Now, chemistry tests may be done, no, such as your protein determination. Okay, so your synovial fluid contains all proteins found in the plasma except for high molecular weight proteins. And these high molecular weight proteins that do not appear in usually normally do not appear in the synovial fluid includes fibrinogen, beta 2 macroglobulin, and alpha 2 macroglobulin. They may be present, however, only in small amounts. So the most commonly used serum protein procedures can be used to measure synovial fluid protein, and usually the range is less than 3 grams per dl. Now, increased protein levels are seen in ankylosing spondylitis, arthritis, or some other arthropathies that accompany Crohn's disease, gout, psoriasis, Reiter syndrome, and ulcerative colitis. Glucose also may be determined in a synovial fluid, and this is usually interpreted using serum glucose levels. Now, a fasting specimen should be used, or at least 6 to 8 hour postprandially. No? So, before we collect a sample, the patient is asked to fast for 6 hours. And normally, synovial fluid glucose levels are less than 10 milligrams than your serum levels. Okay? So, joint disorders associated with decreased glucose levels usually seen in inflammatory joint disorders or maybe in septic joint disorders. We may also opt to determine uric acid levels. No, as seen, there is usually increased uric acid levels in gout. Okay? So normally it ranges from 6 to 8. And the presence of these uric acid crystals in the synovial fluid, higher level, is actually helpful in diagnosis of gout. Another chemistry test that we can do is determination of lactic acid level. So this is usually helpful in diagnosing septic arthritis. So normally your lactate level in the synovial fluid is just less than 25 milligrams per dl, but can be as high as 1,000 milligrams per dl in septic arthritis. Okay. Also, we can do lactate dehydrogenase determination. This can be elevated while serum levels remain normal. This is usually increased in rheumatoid arthritis, infectious arthritis, and gout also. Another test that we could do are serologic tests. Now, this is actually used to determine autoantibodies in the synovial fluid. No? For example, determination of your rheumatoid factor, okay, rheumatoid factor, or your other autoimmune diseases such as seen in lupus erythematosus. Okay? Now, this may also use to determine or confirm antibodies present in arthritis as a complication of Lyme disease. These antibodies are actually specific to the agent Borrelia burgdorferi. Okay? Now, the last test that we could do are actually microbiologic study, wherein the synovial fluid is actually subjected for culture and gram staining. And when you isolate some microorganism, we actually proceed to sensitivity testing. That is to help tailor the antibiotic treatment of the patient. Okay? So this is used to determine the causative agent causing usually present in septic arthritis. Okay. Thank you very much for listening. These are my references. Have a good day.